So my name is Frédéric Michard, and I'm going to talk about AI in anesthesia and critical care. I will discuss temptations, but pitfalls as well. Before I start, I'd like to briefly disclose the fact I'm today leading a consulting and research company, MICO, based in Switzerland, and where we focus on digital innovations with medical applications. So, artificial intelligence, big data, machine learning systems are buzzwords. But what do they really mean for anesthesiologists and intensivists? I'm going to focus on potential clinical applications. So big data clearly speaks for itself. It means today we're able to collect, store, and potentially analyze a considerable amount of data from our patients, clinical, biological information, but also images and even physiologic waveforms. To analyze this data, we need computer power, and today we have it. We can use classical statistical methods, descriptive statistics, to analyze this data. We can also use more sophisticated software algorithm. I have in mind, of course, machine learning systems or machine learning algorithms, which are able to learn to recognize specific patterns or phenotypes or signatures, if you prefer, associated with disease states or adverse events. So it's important to understand that machine learning is a subfield of AI, and deep learning, and I'll show you a few studies done with a deep learning algorithm, is part of machine learning. So machine learning system can first help us to detect and characterize abnormalities. Most applications so far have been developed in the field of imaging. Here is the example of a software which has been developed to detect COVID-19 from CT scan images. So the algorithm has been trained to differentiate between ARDS related to CAP or to the flu or to COVID-19. And you see here a nice example of pretty good discrimination. There is almost no overlap between the different ARDS types. Having said that, most of the time the diagnosis is made simply with a nasal swab, so that's something we should keep in mind. It's not because it's doable that it's clinically useful. Echocardiography, we use more and more echocardiography at the bedside in critically ill patients. Thanks to the amazing innovations, hardware innovation over the last 5 to 10 years. As you know, some probes are actually connectable to a smartphone and fit easily in a pocket. There are also software innovation, and AI is also part of many different ultrasound devices. So with my friend and colleague, Dr. Philippe Gonzalez from the University of Lisbon, we recently published a series of articles on AI in echocardiography. We had the opportunity to test many different devices and algorithms. So regarding AI, we started with the auto-VTI algorithm, which has been designed to compute automatically the subaortic velocity time integral, which, as you know, is a pretty useful surrogate for stroke volume and cardiac output. So in that case, it's a neural network algorithm trained with thousands of cardiac images. And the algorithm is able to detect automatically the apical 5-chamber view and the left ventricular outflow tract. So this is how it looks like, the automatic detection of the 5-chamber view. And you see a green trapezoid around the left ventricular outflow tract. Then the software will automatically record a large number of Doppler signals and select the best signal to compute automatically VTI over a 4 seconds period. You get also user feedback regarding image and signal quality using color coding. And so I share with you here an example where you can see that there is a red trapezoid, then yellow, and then finally green around the left ventricular outflow tract, and then meaning you can trust the measurements once you get this green signal. So we tested this algorithm in this study we published last year in the British Journal of Anesthesia. As you can see, we asked both experts and trainees to use the algorithm, and we compared the measurements to reference manual measurements done by the experts only. And as you can see, we observed a pretty good agreement between the algorithm measurements and the reference measurements, with a percentage error below 30%, both for experts and for trainees. So I think for trainees, it's a very interesting finding. We also tested more recently a real-time LVEF algorithm, which is again a neural network algorithm trained with thousands of cardiac images that automatically detect this time the apical four-chamber view and endocardial borders. So this is an example in a patient with a preserved left ventricular systolic function. You see continuous automatic border detection. Here you have a patient with decreased left ventricular systolic function. From this automatic border detection, the algorithm will automatically estimate the left ventricle volumes and calculate the LVEF. You also get user feedback regarding image quality using color coding. So here another example. You see how the border is red, and then it will become yellow and finally green. And then you can visualize and trust the measurements. So we also did a validation study, an evaluation study that was published last year in Critical Care. Again, we asked experts and novices to use the algorithm, and we compared LVEF measurements with reference measurements done manually by the experts. And you can see again a pretty good agreement. What was interesting in this study is that actually the reproducibility of LVEF measurements was better for novices with the machine learning algorithm than for manual measurements done by the experts. And so I think it's clearly one of the advantages of this automatic system is the reproducibility of measurements. There are other algorithms like auto-IVC for the automatic quantification of IVC respiratory variation in patients who are mechanically ventilated, or auto-B lines to quantify automatically B lines and then estimate pulmonary edema or quantify pulmonary edema in critically ill patients. So to summarize, obviously these innovation, AI innovation in echo are pretty useful, but mainly for novices. And so if you have echo experts in your team, I mean, they may not be actually necessary. Machine learning algorithms have also been proposed for continuous blood pressure monitoring. So how is it possible? So it's continuous blood pressure monitoring from a pulse oximeter. You know, we use pulse oximeters to measure SpO2 and pulse rate, but we also can visualize a pulse oximetry waveform. So if you feed a machine learning algorithm with a huge number of pulse oximetry waveforms, and you give the algorithm the corresponding blood pressure values, then the algorithm will be able to learn how to recognize specific patterns or phenotypes, characteristic of changes in blood pressure, and then we'll be able to predict a drop or a rise in blood pressure. So that's an example of a study done by the group of Patrick Sutker from the University of Lausanne and published a few years ago in Anesthesia and Analgesia. They use simply the pulse oximetry waveform to track changes in systolic pressure on the left-hand side and mean-arterial pressure on the right-hand side during anesthesia induction and tracheal intubation. And you see that actually the algorithm was pretty accurate. The good news is that today we can extract PPG photoplethysmographic waveforms, not only from medical grade pulse oximeters, but also from watches, from rings, or even from optical bracelet. And this is an example of a tool which is now approved for medical use in Europe. And you see on the right-hand side, actually several validation studies done by the developers. However, I mean, recently was published this, I think, first really independent study showing that actually this optical tool was unable to detect the nighttime physiologic dipping in blood pressure, was also unable to track changes in blood pressure induced by medication, meaning these techniques are probably not yet ready for prime time. Machine learning algorithms can also be used to forecast clinical deterioration. So that's what we call, predictive analytics, or the science of prediction. So for instance, we can predict in patients who are in the hospital on the regular wards, we can predict ICU admission or cardiac arrest and death. I mean, the idea is to risk stratifying the future patients who are in the hospital and then decide if they need a very close, or if not continuous monitoring, or if we can continue to ask nurses to spot check vital signs only 4 to 6 hours. So here's an example of a score, the E-card, that was developed using a machine learning algorithm. It's a fusion of age, vital signs, and lab data from the electronic medical record system. And as you can see, I mean, the E-card was actually the best predictor of severe adverse event. It was better than anything else. But as you can see, the MUSE, the National Early Warning Score, the MUSE, which are easy to calculate by any nurse from a vital sign spot check, were also pretty good. So, I like this quote: "A difference to be a difference must make a difference." I'm not sure that in that case, the statistical difference between the E-card and other scores really made a difference or was clinically relevant. Sepsis, the idea would be to diagnose sepsis or to detect patients who are going to develop sepsis at a very early stage, and then to quickly administer the right treatment and maybe improve outcome. Here is an example of a study from Tim Bachman. You possibly know him as the editor-in-chief of Critical Care Medicine. So they developed a machine learning algorithm using 65 variables from the EMR, including vital signs, to predict sepsis in the ICU. And they observed a specificity of 67%, sensitivity of 85%. Specificity 67% means 33% false positive. So what does it mean? It means you cannot use it to treat sepsis, but you can possibly use it to perform earlier bacteriological samples, even if in 33% of these patients, probably they will never develop sepsis. That's a very interesting study published recently. You heard probably about the EPIC system, which is widely used in the US to store and analyze clinical and biological data. And that's a study which is actually very disappointing, showing a very poor discrimination and calibration in predicting the onset of sepsis, raising concerns about sepsis management at a national level. So it's currently a big issue, a big debate in the US. What we can possibly forecast as well is post-operative morbidity and mortality. I mean, that's a very interesting study from the group of Maxime Canesson, published in Anesthesiology a few years ago. They used a deep neural network algorithm to predict post-operative mortality. And you see they observed a pretty nice area under the ROC curve, 0.88, which was significantly, or at least statistically significantly superior to the predictive value of the ASS score. But once again, the difference is not that big. In addition, it's important to keep in mind that with a very basic score like the SWORD score, you can easily calculate yourself without the need for AI. The predictive value is actually comparable. Actually, I love this study because it shows that subjective evaluation by a clinician was as good as what you could get with a SWORD score or what you could get with a very complex machine learning algorithm. So possibly not much room for improvement. Once again, with AI, we can do a lot, but if today we do pretty well with simple scores or even with subjective evaluations, not sure we need more sophisticated algorithm to answer the same clinical question. Few words about hemodynamic stability. It has been proposed as well to predict intraoperative hypertension using a machine learning algorithm that will analyze the blood pressure waveform. That's a paper published in Anesthesiology a few years ago. Pretty good sensitivity and specificity to predict hypertension 15 minutes ahead, 10 to 15 minutes ahead. However, we recently showed that HPI, the hypertension prediction index, is actually simply the mirror of the mean arterial pressure. That was confirmed by other studies. Here's another example published in Anesthesiology. You see the relationship between the MAP on the x-axis and HPI on the y-axis is extremely tight, a correlation coefficient 0.99, meaning that actually when you continuously measure the MAP, you get the same kind of information. And here is another example we recently published with Emmanuel Futier. Obviously, in this example, during surgery, reacting when the MAP is around 70-75 is probably as useful to prevent hypertension than reacting when the HPI is above 85. And that was recently confirmed by this study. There's another study from Anesthesiology, but this one is a really direct comparison between the predictive value of MAP and HPI and showing, as expected, no difference. So you see, regarding predictive analytics, clearly some disappointment. And why that? I mean, it's important to realize there are pitfalls of predictive analytics, at least 4 pitfalls. The first one is to believe that everything is not predictable, or sorry, believe that everything is predictable. Here I will simply quote this paper from Jonathan Chen and Stephen Ash in the New England Journal of Medicine. No amount of algorithmic finesse or computer power can squeeze out information that is not present. And the classical example is what Google X tried to do. They tried to discover a biomarker for depression and anxiety, just analyzing brainwave data. And despite the fact they have, as you can imagine, almost unlimited resources and an army of top computer engineers working on the project, I mean, they failed. It's probably because simply, I mean, the brainwave data they were analyzing, I mean, did not contain the information, the predictive information they were looking for. In addition, in the OR and the ICU, many external factors are susceptible to change clinical trajectories. That's what we try to explain in this paper we published with Jean-Louis Teboul a few years ago. You may have a good predictive algorithm and predicting, for example, no adverse event. If for any reason there is an adverse event, a iatrogenic intervention, for example, a vascular injury during surgery, or for any reason you decide to administer a bolus of propofol, blood pressure will drop. It was not predicted by the algorithm, but obviously it may happen. So it works the other way around. The algorithm may predict an adverse event, but because of therapeutic interventions, you are able to prevent these adverse events. So very difficult, very challenging to predict what's going to happen in a setting where there are very often factors susceptible to change clinical trajectories. The second big limitation is often described as garbage in and garbage out. It refers to the data quality or the poor data quality. Obviously, if you feed an algorithm with wrong data, with artifact, with dumped waveforms, you may end up with wrong predictions. And clearly, a poor data quality is one of the major factors holding up the big data revolution in healthcare. An example with the HPI again, I mean, high fidelity arterial pressure waveforms were used in this validation study. If you do not exclude these high fidelity waveforms, if you just use the algorithm with all blood pressure waveforms you record in your patients, and then of course the predictive value is completely different. You see here the specificity of 63%, meaning 37% false positive. Third limitation, predicting is not preventing. It's obviously very important to bear in mind. Forecasting must be followed by an action plan. Otherwise, you are not, you cannot believe you will be able to change clinical trajectories. And clinicians may not trust and follow AI recommendations. Again, an example with HPI, that's the largest randomized controlled trial published so far. And in this study, they failed to show any impact on intraoperative hypertension when using the machine learning algorithm, whatever the definition used to define hypertension. And one of the explications is that most anesthesiologists actually did not react to the HPI alert. They did not feel the need or the right to give vasopressors or fluid or inotropes to patients who were by definition still hemodynamically stable. And so that's actually a perfect transition to the fourth limitation, which is, which are the risks potentially associated with the treatment of probabilities. If you could predict sepsis, of course, you could perform bacteriological samples earlier, but could you start giving antibiotics to patients who may never develop sepsis? I'm not sure. If you could predict hemodynamic instability, yes, you could upgrade the way you monitor your patients, but could you start treating hypertension in normotensive patients? I don't think so. We're already concerned by the risk of vasopressors, which are known to shut down peripheral or microcirculation, that I don't think it would be reasonable to invite clinicians to give vasopressors to a normotensive patient just because an algorithm is predicting hypertension in 5 or 10 minutes. So in conclusion, big data, AI, and machine learning are buzzwords There are also keywords for startups looking for funds. Machine learning algorithms are very complex, and we should not be naive. I mean, they're going to be expensive, so better ensure that they really bring value at the bedside. In many published examples, the superiority over existing methods remains unfortunately unclear. I shared with you many examples. Yes, you could diagnose COVID-19 from CT scan images, but the diagnosis is usually already made by a nasal swab. Yes, you could ask your residents to use the auto-VTI algorithm to estimate stroke volume and cardiac output at the bedside using ultrasound, but there are probably echo experts in your department who could measure VTI and much more manually. Yes, you could predict postoperative mortality with a machine learning algorithm, but there are studies suggesting that the subjective evaluation of your colleagues is probably as predictive. Yes, you could predict hypertension with HPI, but MAP monitoring will likely give you the same information. These are some of the examples I shared with you. So, there are still a big question mark regarding the clinical usefulness. Of course, the impact on quality of care, patient outcome, and patient safety is not been established yet. And before closing, I just want to share with you this painting. I don't know if you heard about it. It was done by a machine learning algorithm and sold a pretty good price, as you can see by Christie's a few years ago. So the machine learning algorithm was trained with using multiple or a large number of very famous portraits you can see in museums. And then at some point, we asked, the computer has been asked to do one. And that's what we got. So I don't know what you think, but personally, when I thought about this book from Meredith Broussard about artificial intelligence. So just to say that I'm not sure I don't know if artificial intelligence is the future of humankind, but clearly in medicine and in particular in anesthesia and critical care so far, I think AI is clearly overhyped. As clinicians, it's important for us to stay away from novelty blindness and carefully investigate the safety and potential clinical usefulness of digital innovations before adopting them at the bedside. With that, I thank you very much for the invitation again. Thank you.